Dear all, welcome to the session titled Ebola Beyond Borders, Current Realities, Scientific Insights, and Health System Preparedness in MENA. This event is hosted by the Epidemic and Pandemic Preparedness Program at the American University of Beirut Global Health Institute. This virtual panel is convened in direct response to the declaration by the World Health Organization of a public health emergency of international concern for Ebola virus disease in the DRC and Uganda. My name is Jafar Tfaili. I'm the Epidemic and Pandemic Program Manager at the AUB Global Health Institute, and I'm honored to open and moderate this event today. This discussion aligns with the Global Health Institute mission, which was established in 2017 to shift global health toward a model where Global South not only implement, but also design and lead context-driven solutions. Our work is grounded in an interdisciplinary, locally driven approaches tailored to the communities we serve. Within GHI, the Epidemic and Pandemic Program is one of its core thematic programs, focused on creating tools and interventions in the MENA region to enhance the preparedness of health systems in terms of pandemics and epidemics. This program emerged following the COVID-19 pandemic and works to strengthen the resilience of healthcare systems and professionals through research tools, stakeholder mapping, and targeted interventions. To start this discussion, as you all know, the World Health Organization declared the ongoing Ebola outbreak in the Democratic Republic of Congo as a public health emergency of international concern in May 2026. The outbreak has already crossed into Uganda, and with significant population movement across the Eastern Mediterranean region, the question of preparedness is not hypothetical, it is immediate now. This panel brings together experts for a structured and evidence-based dialogue on one of the most serious global health emergencies currently underway. We will run into two rounds of discussion. The first round, we will build the foundation, understanding the virus, the outbreak, and assessing our regional exposure. In the second round, we turn to action, what health system must do, what lessons must be drawn, and what the MENA region needs to prioritize right now. It's my pleasure to introduce our speakers for today's session. We have with us Dr. Naji Aoun, who is a Lebanese-French physician specialized in infectious diseases and currently serving as the Assistant Dean at Balamand Medical University and the Head of Infectious Diseases Department at Clemenceau Medical Center in Beirut, Lebanon. He has over 20 years of clinical, academic, and leadership experience across Lebanon and France. Dr. Aoun has been instrumental in infection control, antimicrobial stewardship, and pandemic response, notably coordinating the COVID-19 task force in Lebanon. He holds multiple French and Lebanese diplomas in infectious diseases, epidemiology, immunology, and quality management, with advanced training from Stanford University. We have with us Dr. EPaPP, who is a medical doctor, researcher, and a civil society leader specializing in epidemic preparedness, community surveillance, and digital health innovation in the Democratic Republic of the Congo. He is the president and CEO of COSAMED, Health Council and Medical Academy, a non-profit organization working to improve health education, medical research, and emergency response. Dr. Badjo advocates for increased investment in health system and universal health coverage. He is also involved in the development of Afia Gap, an artificial intelligence-enabled platform designed to support early warning, outbreak, monitoring, community reporting, and rapid response to epidemics and the humanitarian emergencies in the DRC. We also have with us Dr. Rani Atiye, who is a senior medical epidemiologist within the International Organization for Migration, Regional Office for the Middle East and North Africa, based in Cairo, Egypt. She is a public health physician and epidemiologist with more than 20 years of experience in public health, disease surveillance, outbreak investigation, emergency preparedness and response, migration health, and health system strengthening. We will start our session today with Dr. Naji Aoun. Dr. Naji Aoun, before we discuss what is happening now in Africa and what it means for this region, we need to build a meaningful preparedness. First, we must understand what we are preparing for. So can you walk us through the clinical profile of Ebola, how it transmits, how it progresses, and what makes it a pathogen that demands a specific and serious level of health system readiness?
So, good afternoon, everyone, and thank you for joining us in this discussion. So, as you all know, Ebola is a virus that has been circulating in Africa and well known since the late 90s. So, this virus is a member of the Filoviridae family, and the genus is Ebola virus. We know six species that are recognized actually in the whole world. But the Zaire species, they carry the highest case fatality rate, historically approaching 90% of fatality rate. Now, the latest outbreak in West Africa between 2014 and 2016 had a fatality rate approaching 40%. We'll be discussing later on how the management of the cases and the epidemic will affect these fatality rates. There has been since 1976 at least 34 recognized outbreaks, so it's not something that we are not used to deal with. The only thing is that we need to be prepared. We're always talking about preparedness, and preparedness means three different domains that we will be addressing later on. So, if we're gonna talk about the transmission of this virus, one key message is that Ebola is not airborne. Okay, all the other routes of transmissions are well documented, but it is not an airborne disease. So, direct contact with fluids like blood, vomit, diarrhea, urine, saliva, sweat, and sweat and semen, they are all infectious. So, even dead corpses are infectious. And this has been the main drive for the transmission in the past and in the current epidemics in the DRC. Unfortunately, we have between 5 to 10% of healthcare transmissions when we are dealing with the patients because either we are not equipped or we are not trained. Regarding the survival of this virus on surfaces, it doesn't exceed days. Okay, it depends on the temperature and humidity, but it doesn't exceed days. As we said earlier, deceased patients are maximally infectious through the sweat and the fluids getting out of the body. One issue that is responsible for the low-grade ongoing transmission of Ebola is the persistence of this virus in the semen for at least 9 months after clinical recovery. This increases the risk for secondary transmission even after full recovery of the patient. Now, the reservoir, as we all know, are the fruit bats, and fruit bats are present in the nature. They are present in the trees, and they are present in mines. Mind you that in several countries in Africa, we have miners. They go into some caves, man-made caves or natural caves, and the bats, they are there, and the virus is shedded through the urine and the feces. So they get infected there, and when they go home, they bring the virus with them at home. One critical point for the hospital preparedness is that the infectious dose is very low. It's estimated that we need 1 to 10 organisms to infect a person. So it's one of the lowest dose of infectiousness that one microorganism can have. A single breach in the PPE is therefore clinically consequential. The incubation period is between 2 to 21 days, but let's say on average it's between the first and the second week of symptoms, and the infectiousness onset commence at the onset of symptoms, not before. It's not like influenza. The peak of viremia is between the first and the second week. This is where the patients are highly infectious, and the transmission risk is very high. And this is where the complications start. So when somebody is exposed, after the incubation period, we have a prodrome of 1 to 3 days. Normally, it resembles a viral illness, and the patient then starts to have the wet uh, phase. The wet phase is characterized by diarrhea, profuse diarrhea with vomiting, abdominal pain, fever, and chills. It resembles any gastroenteritis infection or any viral illness or any malaria infection. This is the first week. The second week, with the peak of viremia, we start having uh, uh, septic shock or a DIC phase or petechia, and the patient starts with the hemorrhagic phase. We can have a hemorrhage in the skin. They present with rash, maculopapular. They can have petechia, ecchymosis, and also they can have blood coming out from all the orifice of the patient. He can cry blood. He can sneeze with blood. He can cough blood, and they can have hematuria and even bloody diarrhea. The terminal phase, the recovery phase, occurs after the second week. Either the patient is a survivor and he will recover, or the patient will die. In both cases, patients will remain infectious, and infectiousness will remain up to 9 months in the semen. The pathophysiology of this virus is very tricky because it is secreting a decoy antigen that causes a neutralization of the circulating antibodies. So even if we have previous infections and we are immune, we know that we will develop, we evade this immunity by the antigen that is secreted by this virus. And this will suppress the interferon response that is the main innate immunity that is helping our body against this Ebola virus. Then we will have some endothelial disruption and followed by the cytokine storm. All this will induce a multi-organ failure, and the patient will be in the second phase, the phase that we know as the hemorrhagic phase, followed by the DIC. Um, uh, uh, Treatment protocols are monoclonal antibodies that are practically unavailable in the MENA region, with the maximum supportive care that we can provide to those patients, like transfusions of blood, fresh frozen plasma, intubation, ventilation, hydration, and if the monoclonal antibodies are available, we can administer them to the patient without any high hopes. Finally, to tackle the diagnosis of this infection, we need to have real-time PCR in our lab, and the lab should be equipped with what we call the BSL-3 plus infrastructure, which is unavailable in the MENA area because it's a highly contagious virus, and as we know that the level of organism required are very low to induce the infection. The real-time PCR is provided by the WHO and the reference centers throughout the world. This is the lab identification for us on a epidemiological scale. We should screen our patients coming from the affected area and put them on isolation and treat them as such suspected cases if we don't have any PCR available. Now I'll leave
Thank you, Dr. On.
for the
Thank you, Dr. On.
questions.
Thank you, Dr. On, for this clinical picture that makes clear the pathway clear why the emergence of an outbreak demands an immediate response. Now we will move to Dr. Baggio. Dr. Elia, you are speaking to us from the Democratic Republic of the Congo, where the outbreak is unfolding in real time. What is happening, Dr. Elia, in Africa, and what were the conditions that allowed this outbreak to emerge and sustain itself? And what does the extension into Uganda signal about the limit of national containment strategies?
Yes, thank you, Dr. Jafar. And I thank you very much to Dr. Naji for the presentation. Firstly, what I'd like to give you a little of story how this started. Um, as you said, I'm now on the ground, and our organization is on the front line in all of those three provinces which are affected. And we are working on early warning and communication. Reason why we were there when things started. It was in the month of April, and that is what I'd like to share with you here so that it may not appear in other region because they are also in risk. In April, when the health zone we call Bunia and Mungwalu notified some unexplainable death and illness, which could be as Ebola. We could not. We could also have. We had also community death in one family. Some families we could not even 4 or 5 deaths. That was an alert to the health system. And as the health system knows some signs of Ebola, they take some swab and go to see some sample and go to see if it is or not Ebola. The error was when in the laboratory they searched for Ebola Zaire. We are accustomed to have the Ebola Zaire outbreak every time here in DRC, but they didn't search for Budibunjo Ebola. And it was like negative. About 1 week, and people said it could be such as malaria, and which is very complicated. But death and signs continues, and we observe now those signs in health workers, among health workers. And it now early in May, they said, let us look on other Ebola kind, like Budubunge, if it could be also positive. And then it was positive. The Minister of Health declared now the outbreak of Ebola, but we lost 15 days where we didn't know that we are on we are facing an outbreak of Ebola. The challenge were there. We need to know the list of those people of the death we noted, and then to know their contacts, to follow them. It was a big challenge. Reason why, if you could see the first number of cases, we call them the suspect cases and the probable cases, it was very high. The number was very high. But when they started now to put to set up now the capacity of laboratory on the ground, they started to have confirmed cases, and currently we have up to 600 confirmed cases in DRC, with three provinces which are affected. That time, we can see that things are very hard, but we know that as things are now known, we are going to contain the outbreak. Let us move now, as your question is talking about how the outbreak was going in Uganda. Firstly, it was the first time when we didn't know what is about. People crossing the border. and the outbreak doesn't respect borders. The plane are going from Bunia to Uganda. People went there. If you can see the statistic of data of Uganda, they have now about 19 cases, and among them, 14 are imported from DRC. Only 5 are local cases from Uganda. Why? Because it is a neighbor, and we have a very good movement between Congo and Uganda. And that is a challenge to know those cases and to know what were the contact of those cases. Probably most of them died. We call them probable cases. It will be difficult to have the line where they pass it with whom they was in contact. That is a big challenge. But the hope is there. The plan is on the hand of in the hand of the region with the Africa CDC region and Afro WHO with all governments. And the region took not only those 2 countries, but they took also 10 other countries which are in risk. Among them, we have neighbors of DRC. And we hope things are now going on. There are some challenges on the ground, but we hope things will go in the good line. Thank you. Over to you. And I can talk a bit in preparedness if you need. Yeah.
Thank you, Dr. Eli. As you said, that the current outbreak has already demonstrated that Ebola does not respect borders as it moved from the RC into Uganda. Dr. Eli, what were the factors that drove that cross-border spread, and what does the response on the ground tell us about what functional cross-border preparedness must look like in practice?
Good. Thank you for that good question. And now, the fact is there, people are moving. You can't limit people to move from this country to another. Unfortunately, some countries limited access to Congolese people. They can't get in those countries. But WHO said it is not a good idea to block Congolese people to move from the country and go to participate in conferences or to do their business. It's not a good idea. It doesn't contribute too much to the response. And when the movement is there are some people we don't control. Something which we must do, it is to go to support the response first in where things are going, to support the response there, and then to set up the preparedness plan, as you said. In DRC, we have, as I said, 3 health zones which are affected, but all of health zones we have in DRC, there are 20, there are 3 provinces, I'm sorry, 3 provinces affected, but we have 26 provinces. It means other provinces must have they are having now preparedness plans. And other countries, we have already one plan in the region, in Africa. That's now good. One plan and one team of response. And where we're acting in the response, first is the communication. We must prepare the community with the RCCE, the risk communication and community engagement. Prepare them what is Ebola. We are here in this webinar as the researchers. We know already about Ebola, but that community, do they know also about Ebola? When things will come, they must know. Will not have a resistance as we are having it on the ground here in DRC, because perhaps they don't know it. The second thing, it is the IPC, Infection Prevention Control, in those health facilities where they don't have Ebola, but they prevent themselves, to prevent health workers we are unfortunately we have now noted some death among health workers here in DRC because their protection were not prepared first. It means we must be sure the preparedness and the prevention is in the health facilities. And now the surveillance, the yearly warning must be on place. I'm happy Dr. Naji told us about the capacity of laboratories. They must have the capacity to detect early the virus. And then if they detect early, will not also lose time in the different other regions. They will not lose the time. We have the particularity here in DRC, it is the humanitarian setting and the Ebola. I think it could be the same in the Middle East, where we have also the humanitarian or crisis. And if we don't want it to appear, but we must prepare ourselves. If Ebola is coming also, it could be very hard like here, because some areas we have some, it is very hard to reach peoples. Some areas are controlled by rebels, but it's very complicated, truly. And then we must involve humanitarian coordination and health system coordination. They work all of them together in preparedness and in the response. I think that's what I can contribute at this stage of the debate. Thank you. Over to you, Dr.
Thank you, Dr. Elia. A virus capable of such a spread and an outbreak that has already crossed one international border brings us directly to the question our region must answer. Dr. Atiya, IOM sits at the intersection of migration and health across the Eastern Mediterranean. With significant population movement between Africa and the Middle East, importation risk is real. From IOM's perspective, where do the most critical gaps in the health system readiness currently lie? At the point of entry, in surveillance, in community level detection, and what would strengthening those capacities concretely require?
Okay, thank you so much. Let me thank you first, and thank you for also to extend my thanks to AUP and GHI, and also Dr. Nagy and Dr. Elia for the nice presentation and overview on the transmission of the virus and the response. Let me go and step back to before response to the preparedness. And it is not like detecting Ebola in DRC. It is about detecting the first imported case before it become like the second case, and the second case before to peel the third case. And I will say here and highlight that the preparedness and the vulnerability, it is not about the screening at the points of entry. The greatest vulnerability here happens after the traveler or the migrant enters the country, because maybe the individual or the traveler or the migrant infected with Ebola travel during the incubation period and pass through the points of entry and pass through the screening procedure and tests, and it was like asymptomatic, and days after that go through the hospital or community clinic, and we discovered that he is infected or she is infected. So preparedness, we cannot rely upon only the border screening alone, but requires more and more system integrated approach. From the migration health perspective and mobility perspective, I will highlight the most important gaps that we should focus on. First gap, I think, is early detection beyond points of entry. As I mentioned, the asymptomatic case go during the incubation period and go through screening on points of entry without being detected. Therefore, the preparedness cannot be at the points of entry screening alone, and countries should have integrated surveillance system that connect all together. Altogether, points of entry, event-based surveillance is especially community-based surveillance, health facilities, lab, EOC, public health emergency operation centers. All these things should be integrated together in one surveillance system, and this will help in detecting the early detection. And the question here is whether migrant arrive or not. The question here is whether the health system is able to rapidly identify this case once symptoms develop or not. The second gap is about cross-border data and information sharing. It is a very important one, and the current outbreak shows us that, like, the virus move more faster than information and data can do. So, and many countries still lack operational mechanisms for real-time alert system and system sharing and data sharing, cross-border notification, and contact tracing coordination, and also information exchange between neighboring countries. Preparedness here also include regular cross-border coordination exercise and simulation exercise, data sharing. And it is very relevant to the North Africa population, where population can move, and we have a high rate of movement through formal and informal routes and pathways. The third gap, we should fill it, and we work on it. It is a community-based detection. Imported cases, as I mentioned, are unlikely to be detected through by hospital or a specialized infectious disease physician, but may be likely to be identified through primary health care, community health workers, humanitarian actors, migrant health clinics, or local surveillance officers and focal points. So preparedness requires community-based surveillance system capable of identifying unusual illness or signals, and to transmit and to transfer and escalate these signals rapidly. The fourth gap I want to highlight here also is the lab readiness. Lab readiness is very important to detect, to test these specimens. And many countries have laboratory capacity. Yes, we have, and many of our countries have laboratory capacity, but fewer of them have rapid operational pathways. The question that preparedness assessment teams in each country should ask include many questions, like about the lab, to see the lab gaps. How quickly can the specimen reach a reference laboratory? And how quickly also can testing be performed, and how quickly the results are communicated and feedback to the area of origin. So preparedness is often limited to logistic rather than laboratory technology. The fifth point I want to highlight here of the gaps is risk communication with the mobile population. With risk communication is very important, but with mobile population is more important. Migrants and refugees and seasonal workers and truck drivers and many other cross borders are excluded or not included or not fully integrated in the preparedness plan. Risk communication strategy must be multilingual, must be cultured, adapted, must be accessible to all the people, especially mobile population, and should be linked to trusted community networks. Because preparedness cannot succeed if people are not are like afraid of to report symptoms, due to stigma, they are afraid from consequences after that. So we have to link that to trusted community network and build the trust between them. So Ebola preparedness is not a border management issue. It is the whole system detection issue and the challenge that requires altogether surveillance, lab capacity, risk communication, and community engagement. So altogether should be integrated to detect and to be well prepared to face this challenge we are facing all. And thank you.
Thank you, Dr. Rania. Dr. Aoun, back to you. As we have established the threat, now let us talk more about what health systems must do in the MENA region and specifically in Lebanon, as you are an expert in the Lebanese infection control field. As strengthening health system readiness starts at the facility level, what does EMENA hospital and health system need in terms of protocol, training, and infection control infrastructure to safely manage a suspected case, for example? And what are the most important investments health systems should be making right now, along with laboratory capacities, as we all confirmed that it is a necessity?
So it's gonna be a very costly preparation. If we start with the lab, you need to equip the lab with the level required to do the tests, because even handling the test or transporting the test from one area to a reference center will be a hazardous thing to do. So you need to equip your labs. You need to equip the hospitals with the dedicated units. I used to train and to work in France in Hôpital Bichat. They had a dedicated mini hospital for infectious disease cases, and they used to put the TB patients in it, and then it evolved with time. SARS, MERS-CoV, COVID, and now Ebola. So we cannot geographically select an area in each institution. But anyways, you need to start treating your patients until you decide to transfer them to a more specialized center. So you need to have selected teams in your hospital to be prepared to deal geographically with the patients. And then you need to train the staff and the physicians. You need to train them how to wear, donning and doffing. You need to get the PPEs, and you need to train them not to panic in front of the patients. Because if you're gonna take the scenario that you have a patient coming back from an endemic area with fever, chills, some diarrhea, if every patient will be labeled with Ebola or suspected Ebola, it's gonna be very problematic in the ER. Half of the patients in the ER will start fleeing the ER because they will have a rumor that they are receiving Ebola cases in that hospital. And the other half, I don't know if they will get the appropriate care if the staff is not well trained. So it's a very problematic issue because up till now it's only a reactive preparation. We are not being proactive for that. And we need the special PPEs. The PPEs should be uh, um, waterproof, fully waterproof. And we need to address the waste management, the decontamination, and the biocontainment of the fluids or of the bodies or of the patients that are present inside the hospital. Um, uh, it should be it should start at the level of the Ministry of Health with the program dedicated to teams like we have a disaster management team. We should have a infectious management team present in each hospital that will be receiving Ebola patients. And then on another level, we should train also the ER physicians, at least to start the management of those patients until we transfer them to the dedicated hospitals. And in between, we need to train the transfer teams. In Lebanon, we have the Lebanese Red Cross that is helping in doing this. But from this perspective and Ebola management, we should have a dedicated special team to transfer and to handle those cases. So you have the this is this is the preparedness regarding the resources, and then you should move on to put in place some triage protocols, and then the treatment protocols. We should train ICU physicians and ID physicians how to deal with this. And not to expose a lot of people to the patients, whether it is the healthcare professionals or the visitors. There should be a zero visitors policy so that we can stop the chain of transmission. And finally, that the Ministry of Health should also um, be aware that some patients will die because we don't have any effective treatment, and we need to issue a specific recommendation how to manage the corpse and how to repatriate the corpse from other areas, and how to bury our beloved ones that left us, because we cannot proceed with the normal rituals. If we get exposed to the sweat and the fluids, we can get infected also. It's a very delicate subject, touching a lot of things, not only financial, but also on a social level.
Thank you, Dr. Naji. Facility readiness, of course, must be informed, but by what was actually worked, and you gave France as an example. Dr. Elia, the DRC's experience is unmatched, as we all know. Looking at what has worked and what has not in containing and responding to this outbreak, what are the most transferable lessons for the health systems in other regions and countries that are now assessing and strengthening their own preparedness?
Yes, thank you once again for this question. It is true, the DRC has experience, and even the name of Ebola is one of the river here in DRC. It means it started here. We have the vaccine and treatment of Ebola Zaire, and even one of our researchers was among researchers who discovered that treatment. And unfortunately, about Budibunyo, currently we don't have vaccine and treatment, and that bring put that response very hard. But the experience is that when we have the early detection, as Dr. Naji said, it facilitates with this symptomatic treatment and to manage the case, and some of them can heal. We have now the rate of death is now 20% here in DRC. It means we have now the team which is able to manage the cases, but cases must come early. That is our experience. And cases to come early, the experience said the community must detect first cases and be proud to bring those cases in the health facilities. It means they must be very sensitized and informed to detect cases and to bring them in the health facilities. When cases are also early detected, it means the health workers are informed. That is what also we must work on. That is our experience. And also, we must control the point of entry in the country. Beyond the country, also, some measure must be inside, not only cross borders. Some people who are going out and in the country also, we must control to see is these people having this sign, which is like sign of Ebola, and that people is coming from an area or a health zone which is affected by Ebola, and that is an active surveillance which help to respond and to prevent and to prepare. And over to you. I think I must limit there.
Thank you, Dr. Elia. We close where the regional agenda must begin, with Dr. Atiya looking at the full picture, the outbreak, the cross-border risks, the current state of the health systems in MENA. What are the most urgent and actionable preparedness steps that health authorities in this region must take to be ready for an Ebola importation event?
Thank you so much. Actually, we were discussing that issue during our IOM global and regional meetings recently with colleagues in our MENA countries. And I will avoid starting answering this question. It's a very important one, but by saying we need to have and conduct to have more resources, we need to conduct more trainings. Yes, we need to have all these things. We need to conduct more trainings and to have more resources. But first, we should prepare a preparedness roadmap for facing this challenge and for facing this crisis. We need to have our preparedness roadmap with many pillars and of priorities inside, and to step by step I will go through this roadmap. First step of preparing ourselves to face this challenge and crisis, not only Ebola, but all other crises we are facing or upcoming crisis. First, to review our national Ebola plan. The countries should immediately review Ebola contingency plans if they have or not updated or not, the SOPs if they have or not updated or not, referral pathways, alert verification procedures. All these things should be reviewed first by all the countries, and many plans exist on paper but have not been tested recently. And preparedness plan, as we know, that haven't been tested or exercised before are like assumptions. This is the first step or the first pillar and priority I should or any country should review first. Second, it will be conduct rapid readiness assessment. So we reviewed our plans, SOPs, all things inside. So countries should assess their surveillance system, their laboratory networks, IBC's readiness, isolation capacity, emergency coordination mechanisms. So our objective here is not to produce reports or to assessment reports that we are ready. No, our objective is to identify operational bottlenecks and the gaps before an event occurs. The third step I want to highlight also to conduct and run simulation exercise, CIMIX. One of the most effective and important preparedness investment is simulation. Simulation exercise, for example, if a case, a migrant arriving from an affected area and develops symptoms 5 days after arriving in a local referral hospital. So we want to know what happens next, who is notified, to know the circle, to who is notified, how quickly, how, who collects the specimens, how the transportations, who performs contact tracing, who and why and where, all these things. We should do that, not only ask, we should and practice this. This is a simulation exercise, as exercise reveals gaps that documents never reveal. The fourth step we want to do, it's strengthening cross-border preparedness. The current outbreak reminds us of the previous ones, like COVID and all the previous ones, is that preparedness cannot stop as the national border. We have no borders now between countries. We are like an open world. Countries should establish notification protocols, strengthen their border health collaboration, and conduct joint preparedness activities, and to participate in regional information sharing, and to have coordination between country and the other. The fifth step I want to highlight, because it's very important. It is how to protect the protectors, how to protect healthcare workers, how to protect people working to support cases and to treat cases, and to and surveillance and many other, to protect healthcare workers. In history, we know that, like it was said and known, that health workers' infections are often early indicators of system weakness. It's very important to know that. So preparedness must ensure that we have IPC and IPC trainings, we have sufficient and very good PPEs, and we have triage systems and mechanisms, safe patient transportation, and also we should have and ensure that we have occupational health measures. From IOM perspective, it's very important to recognize that that MENA region is not only a destination region, but a major transit region and a mobility corridor connecting and linking Africa with Asia and Europe. So the region experiences large movements of migrant worker, refugee, displaced population, traders, and many mobile population through regular and irregular pathways. And many of these movements occur in fragile or conflict affected areas, where surveillance and access to health facilities and services may be like a very important and difficult challenge. This means that preparedness efforts must extend beyond formal points of entry and ensure that surveillance, risk communication, community engagement, referral system effectively integrated and reach mobile and hard to reach population, and preparedness system that doesn't include and doesn't account for population mobility is not a fully working one, and it's not a fully prepared one. Thank you.
Thank you, Dr. Rania. Thank you, Dr. Elia and Dr. Naji, for your meaningful interventions. In this context, one of the key takeaways from today's discussion is that preparedness is key in eliminating outbreaks. To support this, as the Global Health Institute at the American University of Beirut, we are now offering 12 scholarships for the enrollment in the Epidemic and Pandemic Program. The certificates aims to enhance knowledge and skills in addressing these complex challenges. It is accessible through our online learning platform, GLAD, and was intentionally designed to be relevant and regionally focused on the MENA context. It is accessible especially for professionals balancing work and learning. The certificate is composed of 4 self-paced courses covering the topics that you are seeing on the screen. Individuals have the choice to undertake individual courses if they are interested in a specific topic, but as soon as they complete the 4 courses, they will receive the certificate. All of our certificates are AUB JHI certified for institutions that are interested in purchasing for their organizations. We also have institutional packages, so feel free to reach out to us to get more information. Thanks to all our participants for joining us. This marks the end of today's session. Have a wonderful day, and thank you again, our esteemed experts.